Welcome you all. Today's topic is trigger asynchrony in mechanical ventilation. I am Dr. M. Nurul Akhtar Hassan, pediatric intensivist and associate professor, pediatric intensive care, National Heart Foundation Hospital and Research Institute. Today we shall discuss patient ventilator asynchrony, adverse effect of patient ventilator asynchrony, types of asynchrony, trigger asynchrony, and finally a summary of this thing. So in controlled breathing or controlled mechanical ventilation, breathing is entirely controlled by ventilator. That is, there is no part from patient. Ventilator will deliver a fixed number of breath after certain period of time as we set in mechanical ventilator. This type of controlled ventilation actually we don't practice commonly or for a long time, only applied for short period of time during acute phase or in severe comatose patients or in severe anesthetized patient during surgery. And this type of controlled ventilation is associated with respiratory muscle inactivation and ventilation induced diaphragmatic dysfunction. The other form is assisted ventilation. In assisted ventilation, patient's respiratory system and ventilator work together. That is, when patient tries to take any breath, ventilator understand that thing and deliver a breath in synchrony with patient. So there is nice synchrony between patient and ventilator. As a result, there is less requirement of sedation and muscle relaxation and less risk of polyneuropathy and diaphragmatic dysfunction. But for this assisted ventilator or assisted ventilation, we need the trigger to be set appropriately. If we don't set trigger appropriately, there will be asynchrony. So this is also we discussed during our last webinar, the 4 basic parameters determining mechanical breath: trigger, flow, limit, and cycle. Trigger we discussed in detail. Trigger is the initiation of breath, how a breath will be initiated. It can be flow, it can be pressure. There are other forms we shall not discuss. Pattern of flow. Flow means when the lung will be expanded, what will be the pattern of flow the ventilator will deliver inside the lung, whether it is constant flow or decelerating flow. And the limiting the breath, how the breath will limit, how the lung will expand to a certain limit and up to a volume limit or a pressure limit, which is popularly known as volume control or pressure control. And finally, termination of breath, that is cycle, how the breath will terminate, when the breath will be terminated, after a certain time or after delivering some amount of flow. So this trigger we discussed earlier, and this flow, limit, and cycle we shall discuss during our next webinar in detail. I am not going in detail today. So this is also we discussed during our last day, that is 2 types of trigger is there: time trigger, patient trigger. Time trigger means patient will not take any part. After a certain period of time, ventilator will deliver a breath, and this depends on the set respiratory rate of ventilation. So after a certain period of time, ventilator will deliver a breath. But in patient trigger, patient will trigger or patient will show desire or patient will need a breath, patient will take a breath, and ventilator will understand that patient is in need of a breath and ventilator will deliver a breath. For this we have to set patient trigger, and that can be pressure trigger or flow trigger. These are the most common. Other forms are there, we shall not discuss today. These are very rarely used and only available in certain modality of ventilator. So what is patient ventilator asynchrony? That is, the initiation and or termination of a mechanical breath is not in time agreement with initiation and termination of neural breath. অর্থাৎ পেশেন্ট শ্বাস নেয়া এবং ছাড়া, ভেন্টিলেটরের শ্বাস ডেলিভারি এবং ভেন্টিলেটরের শ্বাস বন্ধ করা, এই দুইটা যদি পেশেন্টের সাথে সিনক্রনি না থাকে, তাহলেই আমাদের এই পেশেন্ট ভেন্টিলেটর অ্যাসিনক্রনি ডেভেলপ করবে। আবার if the magnitude of mechanical assist does not respond to patient respiratory demand, অর্থাৎ ভেন্টিলেটর যতটুকু ডেলিভারি দিচ্ছে পেশেন্টের জন্য প্রতিটা শ্বাসে, সেটা যদি পেশেন্টের জন্য অ্যাডিকুয়েট না হয় তাহলেও সেটা অ্যাসিনক্রনি তৈরি করবে। সো দ্যাট ইজ পেশেন্ট ভেন্টিলেটর অ্যাসিনক্রনি। Patient ventilator asynchrony has significant untoward effect in terms of discomfort, dyspnea, sleep impairment, worsening of pulmonary gas exchange, increased work of breathing, periodic breathing, alveolar overdistension, and lung injury. And the dangerous thing is diaphragmatic injury, ventilator induced diaphragmatic dysfunction. There will be increased use of sedation and muscle relaxant use, and finally increased duration of mechanical ventilator, weaning time, and mortality. So there are host of issues related with this patient ventilator asynchrony. So asynchrony must be addressed and must be taken care of. So there are common types of asynchrony that are trigger asynchrony, cycle asynchrony, or flow asynchrony. So there are three types of asynchrony. These are three types of asynchrony: cycle, trigger, cycle, and flow. We shall not discuss cycle and flow today. Subsequent lectures we can discuss because we have time limitation. So trigger asynchrony can be delayed trigger, ineffective trigger, double trigger, reverse trigger, auto trigger. Trigger can be delayed trigger, ineffective trigger, double, reverse, or auto trigger. The 5 type of trigger asynchrony can happen. We shall see one by one. There are ventilator factor or patient factor. In ventilator factor, there can be inappropriate sensitivity setting. So if we set the trigger inappropriately, say too high or too low, if we set, say, a neonate, for a neonate trigger should be minus 0.3 to minus 0.5 or 0.3 to 0.5 if flow sensor positively, so 0.3 to 0.5 for neonate. But if we set 3, then that would be too high for a neonate, and high sensitivity setting means low sensitivity actually. So in that case there will be insensitive or delayed trigger. Malfunctioning of the trigger mechanism, prolonged inspiratory time. So if patient is having a prolonged inspiratory time, that also can cause triggering problem. And auto PEEP, that is hyperinflation of the lung. If there is very short expiratory time or hyperinflation of the lung, then it can cause problem. So we have to adjust the trigger appropriately. And we discussed earlier, flow trigger is more sensitive than better pressure trigger. That is, if you set trigger plus, say, 0.5 or 1, that is more sensitive rather than setting minus 5 or 0.5 or minus 1. So if there is a inappropriately high inspiratory time, that has to be decreased, and tidal volume or peak pressure to be reduced to avoid hyperinflation. And from patient factor, if there is too high sedation, too much high sedation, or there is respiratory muscle weakness, there is a decreased neural drive and auto PEEP, hyperinflation, then also there can be trigger asynchrony or ineffective triggering. In that case, we have to reduce the sedation or neuromuscular blocking agent, and to minimize hyperinflation, PEEP has to be decreased if there is hyperinflation in X-ray, and pressure support or tidal volume has to be decreased. This is one example of ineffective triggering. This is a flow waveform, and this is the pressure waveform. So you have to follow this waveform in monitor to understand trigger asynchrony. You will be able to understand if you can follow. This is flow waveform and this is pressure waveform. So this is inspiration and this is expiration. So if you see, this is here patient takes a respiration, tries to take a respiration, and one respiration was delivered. But when here patient tries to take respiration, there is a negative indentation in the airway, but no ventilator respiration was delivered. So this is an example of ineffective trigger. and in flow also you will find some upward movement, but there is no respiration was delivered. So this is a fine example of ineffective trigger. Here again respiration is delivered, but again here the negativity is there, but ventilator could not detect this effort, so it was an ineffective trigger. Maybe trigger was set too high, making that insensitive. This is another example. This is a pressure waveform and this is flow waveform, and this is electrical activity of diaphragm. So here diaphragm is moving and ventilator is detecting and a respiration is delivered, but here maybe diaphragmic activity is low, that's why here negativity is there, some negativity is there, but ventilator could not detect that negativity, so no respiration was delivered. So this is another example of trigger asynchrony. Here again no respiration was delivered, though patient tries to took a respiration, there was mild positivity, but maybe trigger sensitivity was inappropriate. So we have to set the trigger sensitivity appropriately. This is another example. This is flow waveform, and this middle one is pressure waveform, and down below one we cannot do this thing, but this is in research purpose they use. This is esophageal pressure. When patient tries to take respiration, there is drop in esophageal pressure. So here esophageal pressure dropped down and one respiration was delivered, but here esophageal pressure was not that much, so patient could not detect a respiration was not delivered. Ventilator could not detect patient's effort. Here respiration was delivered, here delivered, here again delivered, but if you can understand, if you can see here, here the first dotted line is the patient effort, and after some delay patient ventilator delivered a breath. But in this thing, here again in the first dotted line patient's effort, and after a significant delay in comparison to first one, a respiration was delivered. So this is the triggering delay. This is a dysfunction of ventilator. So this is not a problem in case of this is not a problem in case of adult patient or a big patient, but if neonate, say in neonate is a inspiration time is 0.3 second only, and if trigger delay is 0.2 second, then when patient ventilator delivered a breath, by this time patient already completed his own 2/3 of his respiration. So this is very important. Triggering delay is important for neonate or old younger infant, but we the thing is actually this triggering delay problem is more pronounced in older version of ventilator. The newer version of ventilator, they are very smart and triggering delay is less. Our second thing is double trigger. Ventilator delivers subsequent 2 breath when patient is taking 1 breath only, and it happened if inspirated time is too short set. Say patient's inspirated time is not set appropriately. Say for a infant or a older children 5 years, inspirated time should be 1 second. But if we set 0.5 second, that is too short. In that case, double trigger may there, and inspirated time has to be set appropriately. Or if there is a low tidal volume or low peak PIP is set. Another thing is cycle of, I am not going here. This cycle we should not discuss today, this cycle thing. So this is an example of double trigger. If you see here, the patient is trying to taking a breath and one breath is delivered, and one end breath is delivered, but here patient effort is just double the previous one. Here the inspirated time, this is the patient inspirated time is too long, but as ventilator inspirated time is set too short, so one ventilator breath was delivered, but patient when ventilator completed his breath, patient is still on inspiratory phase. So ventilator thought patient is taking another breath, and ventilator delivered another second breath. So subsequent 2 breath is delivered. So here subsequent 2 breath is delivered, and this is called double trigger. You may find this abnormality in ventilator, but you did not understand what's going wrong. That actually double trigger due to inappropriately set inspiratory time. Patient inspiratory time is higher than ventilator set inspiratory time, so it has to be adjusted, it has to be as per patient need or patient age. This is another example of double trigger. Here ventilator delivery is ventilator breath delivery is complete, but patient is still in inspiratory phase. So another delivery, another respiration is delivered. Second thing is double reverse trigger. Reverse trigger is somehow similar to double trigger, but this is happened due to unknown mechanism, and it happened in severely or very well sedated patient, very sedated patient. It happened. So and it's occurred due to insufflation of lung. Here you see is like previous one double trigger, but in double trigger actually there is less gap between two breath, and inspiratory time is not too long here. Inspiratory time is not too long. So reverse trigger also there will be two serial breath, but in that case it is not due to patient's inspiratory time, but it is due to deflation of lung, and it happened in two sedated patients. So sedation has to be decreased. So if we go back to our previous example, if you see when normal breath is delivered, tidal volume, say this is in adult patient, 500 ml tidal volume is delivered, but when double triggering is there, almost 1 liter of tidal volume is delivered. So this is very high, and it will cause lung trauma. So to understand, differentiate between reverse trigger and double trigger, in double trigger and reverse trigger there will be subsequent two breaths delivered by ventilator. Here you see subsequent two breaths delivered by ventilator, but in double trigger patient's inspiratory effort would be very good, but in reverse trigger there would be less inspiratory effort and patient will be too much sedated. If we reduce the sedation, patient will behave better actually. Okay, this is another example of double trigger. And then finally we have auto trigger. This we discussed earlier, and this is probably most common, and this happened due to excessive sensitivity. Say if in a older children sensitivity has to be set 1, but if we set it 0.5 or 0.3, then that would be too sensitive. So that can cause auto trigger. Or if there is leak in the circuit or water in the circuit, then it can cause auto trigger. So we have to optimize the trigger setting. We can change to pressure trigger rather than volume trigger. That can help in this to prevent auto trigger. If there is circuit leak, that has to be checked, circuit water has to be removed, and too much secretion has to be removed. And other thing is patient's cardiac oscillation may be falsely detected by ventilator. This is the example of auto trigger due to circuit leak. Say here leak is there, so as there is leak, one extra delivery is there, breath is delivered by ventilator. But if you see patient effort, here is the patient effort, here ventilator delivered a breath, but here there is no patient effort, but ventilator delivered the breath due to leak. And here also no effort is there, but due to leak ventilator is thinking patient is taking breath, another auto trigger. So these are due to circuit leak, and this is due to cardiac oscillation. If you see the lowest line, purple line, there is not a single attempt of patients, but these are the cardiac oscillation, and this cardiac oscillation is patient detecting as the ventilator detecting as a patient's effort and delivering a breath. So it can happen due to if there is too sensitive trigger. So trigger has to be set appropriately. And this is another example. Here no effort of patient, but ventilator is delivering a breath. So inappropriately set patient event trigger. So in summary, it may be largely underestimated, that asynchrony largely underestimated because of frequent lack of monitoring and frequent and lack of understanding. Physician must pay more attention to the interaction between patient and ventilator. Asynchrony may occur at any phase of respiratory cycle, can be due to time discrepancy or ventilator assist respiratory demand discrepancy. Deep sedation should be avoided when possible. Asynchrony negatively correlate with clinical outcome and the gold standard for their recognition is documentation of patient effort and to follow the waveform. We can discuss the waveform in future also. And careful inspection of ventilator screen along with clinical picture of the patient is sufficient for the physician to recognize patient ventilator asynchrony. Actually, if you follow the ventilator waveforms, you will understand the asynchrony. So thank you all. You said in double trigger the tidal volume is high, but in auto trigger and reverse trigger, what will happen in tidal volume? Auto trigger and reverse trigger also there will be high tidal volume delivery, but in auto trigger there will be high minute volume delivery because there will be too much respiratory rate, and as a result there will be too much minute volume delivery. So if you allow too much minute volume delivery, then there will be carbon dioxide washout. What we do then? Deep sedation or no? If there is auto triggering, too much auto triggering, you have to adjust the trigger appropriately, and you have to find out the cause of auto trigger. Where there is water in the circuit or leak in the circuit, you have to ensure that thing. Leak has to be reduced, circuit water has to be removed, and if there is secretion, that has to be suction out. Dr. Simi, to my understanding, asynchrony should be checked from ventilator monitor periodically. Is there any protocol for suggestion how frequently? No, this is not how frequently, this is continuous thing. You have to check continuously in the screen monitor, and you have to train your nurses also to understand the monitor's flow and waves. And is there any problem with too much changing of trigger setting? Usually you don't need to change trigger too much actually, and you should not require also that thing. So do the graphs will indicate there is asynchrony? Yes, definitely graphs will help to understand. Probably the only one thing, important thing is the graphs, that can help us. Next day actually we shall discuss 4 basic parameters determining mechanical breath, that is trigger, flow, limit, cycle. So these are the complex thing, as Dr. Tarek told, these are the complex, but if we don't understand this complex thing, these are complex because we don't understand this thing, and we did not go into deep into this thing. If we understand this thing, then this will be like easy like anything. So our next webinar will be on 4 basic parameters determining mechanical breath, that is trigger, flow, limit, and cycle. Before that, thank you all.